Second question, what about rural and underserved populations like Eastern Ohio and Appalachia, where I live? What can Congress do to facilitate more adoption of these technologies across smaller and rural practices to make our healthcare system more personalized and ensure every patient and provider has access to the highest quality healthcare technology?
Yeah, that's another great question. And so we learned through the pandemic that there's basically a one-to-one relationship between having enough healthcare providers and the patients that you need to take care of, that ultimately providers deliver care. And so the way we see AI helping solve this problem is by literally freeing them up from tasks that are not focused on caring for those populations, so that we can, in a sense, increase the size of our healthcare workforce without actually needing more bodies, but just through AI.
Yeah. One final question before my time expires here. Can you, and you can answer this for the record if you would get back to me because my time has expired. How can we facilitate, what can Congress do to facilitate more private investment into these technologies to make them more useful to the healthcare system?
Yeah, thanks
for the
question.
If you would get back to me, I'd appreciate it.
I will.
I yield back, Mr.
The gentleman yields back. And I now recognize the gentlelady from Washington, Dr. Schreier, for 5 minutes.
Thank you, Mr. Chairman. Thank you to all of our witnesses today for this interesting conversation. Artificial intelligence and machine learning are already transforming how we study and practice medicine. And as we continue to grow these capabilities and to make further breakthroughs, it's really important that Congress keeps up, and I thank you for this education. Last spring, Mr. Shen, I loved visiting Siemens Ultrasound Research and Development Center headquarters located in my hometown of Issaquah, Washington. And during my visit, I learned about and got to see pretty incredible innovations being done. One of them was the ability to diagnose non-alcoholic fatty liver disease in an ultrasound scan that took less than a minute, and to be able to catch this early. And the implications for morbidity, mortality are incredible. But, you know, every time we have a new advance, there's this question of cost. And as we integrate artificial intelligence and these more advanced algorithms and new technology, there are impacts on costs. There's development impacts, but there's also potential cost savings down the line if you're avoiding liver transplants. I was wondering if you could, I have two questions, so just kind of partition your time, kind of comment a little bit on AI development and cost.
Yep. Thank you for the question, Congresswoman. And of course, we were very happy to host you at our Issaquah facility. As it relates to artificial intelligence, as you correctly noted, we're trying to integrate AI tools directly into the types of exams or devices that are touching patients here. So here, in this case, for ultrasound, being able to integrate the AI and not have it as be a separate type of solution there. So doing that in itself reduces some of the costs. So rather than trying to have a separate AI solution that has to be maintained, has to be procured or whatnot, we actually integrate those solutions directly into the medical devices that are treating the patient. So that's one aspect of it. And then as we look at AI overall, we do want to look at not just the cost of procuring that AI, but what is that downstream cost? What is that benefit, not just to the patient in terms of maybe fewer days that they have to spend at the hospital or maybe shorter time to diagnosis or to treatment, but also cost savings that could be realized by the provider themselves as well. So that the provider, by deploying this type of technology, is able to be more efficient, is able to make that diagnosis faster, is able to see more patients because they now have more time to be able to take care of one patient and move quickly to the next patient. So these are all things that we think about as we develop AI algorithms.
Thank you. I appreciate that. My next question, I want to talk to, pivot to Dr. Longhurst, and this is really about the impact of AI on the physician-patient experience. Ranking Member Eshoo talked about the patient experience. I'd like to talk about a little bit about the doctor experience. And I can understand how nice it would be to have the latest research pop up as a suggested pathway for a given patient who I'm seeing, who's maybe already filled out their whole history for me. But doctors are already burnt out. We've been compared in an op-ed to cogs in a wheel, to line workers, after almost a decade of training post-university. And we're being asked to see more patients faster, do more things in a visit, and we're burning out. And so I wanted to talk with you about kind of the physician-patient relationship, the trust that's there, how physicians feel when, perhaps they're just becoming a check on a system where AI makes patient management decisions for them after that kind of training. Can you speak about that?
Yeah, thank you, Dr. Schreier, and it's a real privilege to speak with a fellow pediatric graduate from Stanford. When I was at Lucile Packard Children's Hospital, we were in the process of implementing the electronic health record. And as we all know, the electronic health record, if not the primary cause, has become a primary symptom of burnout. The many hours that our pediatricians, physicians in general spend documenting the electronic health record is contributing to a national epidemic of what we call pajama time or after hours work. We know that for every day spent in clinic, the average physician spends about 2 hours documenting electronic health record to ensure regulatory compliance, billing, and other things. And so where the electronic health record was a really important digital infrastructure for collecting data for quality and population purposes, it's introduced these unintended consequences. I'm incredibly optimistic about AI, particularly the AI scribes that Dr. Schlosser described as being a solution to help decrease the burden that was introduced by electronic health records. So we're seeing just incredibly positive results from pilots using these scribes. Unfortunately, the technologies are still quite expensive, but as they become commoditized and continue to demonstrate outcomes and privacy, I think this is going to help us to remediate some of the burnout that has happened over the last decade.
Thank you. I appreciate that. I yield back.
Generally yields back. I now recognize myself for 5 minutes. While I'm only just beginning to learn about how AI can contribute to healthcare, I recognize it has great potential. I was a cardiothoracic surgeon before I was in Congress. And I do believe that ultimately technology used properly will help us control cost. I really believe that. As an example, a top priority of mine is legislation that would allow real-time prior authorization decisions by Medicare Advantage plans and ultimately by all health plans. I recognize that AI would make real-time decision-making far more feasible and expect that it would be used for this purpose. At the same time, we're hearing allegations that health plans are making coverage determinations using AI-powered tools that are ultimately shown to have high rates of errors, as was mentioned by Ms. Eshoo, the ranking member, in her opening statement, resulting in patients paying more for health care or perhaps foregoing necessary medical interventions. Basically, these are improperly denied claims. Recent media articles have outlined this situation, which is unacceptable, and I would argue that this should be investigated by Congress. I say all of this to remind my colleagues that our approach needs to be balanced and to remind the companies using AI to do so responsibly. Just a statement, Mr. Schlosser, as long as the AI can properly populate the record to obtain appropriate reimbursement for the providers involved in the case, you'll see wide acceptance of it. Even if their record is there, but it doesn't properly reimburse the provider for their care, then it'll be a struggle, and I'm assuming it will probably do that. That's a major issue for providers. The documentation that is required by the federal government for reimbursement, honestly, in my view, has been a problem for a long time. Another issue in our healthcare system we will need to think about is using more AI in how we train and educate medical professionals to use it appropriately. I'm going to address this to Dr. Nguyen. Your testimony mentioned using AI to train and educate medical professionals. There may be a risk that our future providers will become overly dependent on technology, resulting in less well-trained providers in the art of clinical decision-making. I'll give you an example, Google Maps. It's not direct, but I have adult children who are in their 20s. I mean, they can't navigate anywhere without Google Maps. I mean, they literally don't know what direction they're going. To go around the block, they map it. I would call that an over-reliance on technology. It's not a direct correlation, but kinda. So how do we begin to train these professionals on the uses of AI and increase the awareness of the pros and cons? And is that something that medical schools are beginning to think about? And if not, should we be?
Thank you, Dr. Bouchon. That's a very prescient example. I, too, have a lot of trouble navigating without Google Maps, so I fully understand that. I think that, our institutions, very rightfully so, focus on the art and science of medicine, right? At the same time, I think it is very, very important that institutions leverage these new AI technologies to create learning experiences, first to enhance the learning experiences and make them more efficient, enabling students to really hone in on the most important concepts that they need to know in an efficient amount of time. Second, I think it's very, very important that these institutions train and educate their students on the nuances of these technologies. It will be unavoidable that doctors of the future use these technologies, whether or not they are trained in them. And so the most important way to prevent over-reliance is to educate them on the limitations of that technology.
I would agree with that. Don't get me wrong, I'm a big supporter of technology and innovation in the healthcare space. I guess, Mr. Shen, you can talk about maybe, real time. Are we seeing medical professionals real time over-relying on AI as it relates to the evaluation of, for example, CT scans, MRIs, X-rays? Are the people coming up being properly trained, I would say, I guess, on the positives and negatives of this situation? I mean, that's going to be really important, right?
Yeah, no, this is a great question, Vice Chair Bouchon. I think to echo what Dr. Nguyen was talking about, what's critical here is transparency around the artificial intelligence, not in terms of how you actually use the AI, but how is the AI making that clinical determination and educating these upcoming physicians on how the AI is actually making that clinical determination.
Thank you both for the answer to that question. It's really important. Now, I recognize Ms. Custer from New Hampshire, 5 minutes.
Thank you so much, Mr. Chairman, and thank you to all of you for sticking with us. We appreciate it. Today's hearing is an opportunity to understand how artificial intelligence can help patients, providers, and researchers. To fully realize this potential, we need to ensure that AI tools are safe and equitable. I want to use this hearing to discuss one opportunity and two concerns I have with AI health. For the opportunity, I'll look to Dr. Newman-Toker. In your testimony, you describe one potential benefit to AI is that it can improve patient outcomes through more accurate diagnoses. Could you give us some examples of how AI tools could benefit public health?
Yes. So, thank you very much, Congresswoman, for the excellent question. As I noted in my testimony, we've recently estimated that about 800,000 Americans die or are permanently disabled each year from diagnostic error with serious medical illnesses like stroke, heart attack, pneumonia, sepsis, et cetera. There's an enormous potential public health impact of being able to close that gap, that quality gap, with AI-based detection of using laboratory data and vital signs for things like sepsis, using video-based interpretation of eye movements for stroke diagnosis is some of the work that we've been doing. So I think there's tremendous potential in that space, and at the same time, to deal with some of the concerns raised earlier about costs, because when you realign, when you actually improve diagnosis, what you do is you cut down on both false positives and false negatives at the same time. And by doing that, you save lives by catching the cases you had missed, and you cut costs by not over-investigating the patients that didn't need that investigation. So I think it's a tremendous public health opportunity.
Good, thank you. Two concerns. I'm worried about bias in the data. Continuing with Dr. Newman-Toker, you also state in your testimony for AI tools to be maximally beneficial, they must be properly validated and utilize gold standard data sets. What steps can companies and researchers take to ensure that the data that's being used to train AI systems is accurate and without bias?
Thank you for the wonderful question. I do believe that this is the foundational challenge that faces this whole area of AI in healthcare. The issue of creating gold standard data sets is there's not a simple solution to that problem. We actually have to do things in healthcare that we don't normally do, such as, for example, determine what actually happens to our patients downstream after an encounter. So we say, for example, that a patient leaves our care and they have X diagnosis, but we don't actually know if that's true. We often don't get that follow-up. They may go somewhere else. They may end up in a different health system. So we have to start coordinating data architectures, and we have to start developing and curating good data sets that can be used at a large scale to train these AI models. So I do think that that's going to take a big effort, and one that would be best coordinated federally.
Helpful, thank you. And my final concern is about protecting patient data when we are developing AI tools. Dr. Shen, I appreciate Siemens Healthineers' commitment to protecting patient data. Unfortunately, we've seen an increase in healthcare cyber attacks, which have more than doubled from 2016 to 2021. What steps does your team take to ensure patient data being used to train AI tools is protected from cyber criminals and just plain bad actors?
Yes, very, very, very timely question, and really appreciate that, Congresswoman. So here at Siemens Healthineers, we take data privacy and patient data privacy as a core component to how we approach the development of artificial intelligence. And to that respects, as it relates to securing the data, one of the important aspects that we do is that any of the data that we utilize to train our AI algorithms is fully protected in our big data office that's there in Princeton, New Jersey. So there are physical limitations that are set already in place, that physical barriers that don't allow individuals or bad actors to gain access to that data center there. And then from a cyber standpoint, what our big data office does is that they actually control who has access to the data itself, and in terms of controlling internally the audit that's needed in terms of who are the users that can access that clinical data to do the algorithm training. So they have the ability to audit the user access and restrict the user access to only the individuals who need to be accessing that data.
Great, thank you. I'm all set. I'll yield back.
The gentlelady yields back, and the chair recognizes Dr. Dunn for 5 minutes for questions.
Thank you very much, Mr. Chairman. I appreciate all the insights from our witnesses regarding the role of AI in the clinical setting. I believe there's an important debate to be had about the value add versus the risks of AI in the doctor's office and the hospital. And I agree with our witnesses about the promises of this technology in medicine. I also echo Dr. Nguyen's caution and careful consideration when AI is utilized for clinical decision-making without close physician oversight. It's clear from the advances in AI, from narrow AI to the generative and large language models, that there's sweeping implications for the delivery of healthcare, and it presents clear opportunities and challenges. I'm encouraged by the efforts to explore the role of AI in interpreting radiology and pathology. And although I think the current evidence demonstrates that this is not quite ready for prime time, I'm certain that that will become more sophisticated over time. I am especially optimistic about the ability of AI platforms to reduce administrative burdens and simplify clerical tasks. I appreciate the questions that Dr. Schreier asked on that in that queue, and that's a real problem. As we all address burnout, physicians are spending a quarter of their time or more on administrative tasks. So that's a huge. I would have loved to have had that when I was practicing, quite honestly. I do have some concern that the private practices may struggle with the upfront cost of adopting AI technology, and I urge the industry to think creatively about ways to provide access to that technology to the full spectrum of provider settings. And to echo Mr. Johnson's concerns with our rural communities, rural providers who will be further disadvantaged if they don't have access to that. If those technologies are only accessible to those with the resources, we may have an even worse shortage in rural medicine. So Dr. Nguyen, can you briefly comment on any specific challenges that rural or private practices may face when trying to adopt something like Transcarent?
Yes, Congressman. So to address your question, I think there are always going to be challenges with the rural and private practices, which are just simply smaller in size, smaller in staff, smaller in budget, right? The challenges come in many ways, shapes, and forms for any technology adoption, AI included, and that is the capacity to assess, right, the right tools to adopt and the budget to adopt them. I think it's very, very important, right, to continue to support the development of AI tools amongst the private industry in a safe and non-biased way, because that is actually, in my opinion, the fastest way that ultimately a lot of these practices will experience and be able to use these generative AI tools is when the vendors and the tools that they use begin to incorporate those, right? When we began adopting EHRs, right, most of these private practices had access to EHRs once vendors began to build it for those practices specifically.
You know what I'd like to do? I'd like to do offline, out of this hearing, have somebody from your company come tell me what's your pricing mechanism, you know, for different practices and how they can you know, adopt that in their office. So that'd be something we could do separately. Dr. Schlosser, briefly, what are some of the ways you've seen AI improve efficiencies for patients, improve their experience?
Well, one thing that all the clinicians and probably everyone in the room will acknowledge is that we ask patients the same questions over and over again. We're constantly burdening them with delivering their entire health history at each interaction along a healthcare journey. And then if you change systems or go to a different physician, you start that entire process over. So I think the ability of AI to help us wrangle this entire universe of healthcare data that exists across multiple disparate EHRs into a longitudinal record of the patient that clinicians and patients can easily access.
Just access, you're right. So I spent more time as a patient than a doctor the last few years up here in Congress. I have to tell you, I filled out my history probably 1,000 times.
Yep.
It's just amazing experience to me. Dr. Longhorst, your testimony, you made reference to a study, I believe you were a co-author on that study actually, in which an algorithm was rapidly deployed to analyze chest x-rays in COVID-19 patients. Every clinician I know has been reading chest x-rays for 40 years. What specific advantages did you confer to these physicians?
Yeah, great question. Thank you. I can tell you the day that we rolled this algorithm out that I walked through the emergency department and asked if our attending physicians had used it. And one of them said, yeah, last night we got a chest x-ray on this woman who was in for cardiac symptoms. We didn't see a sign of pneumonia. The radiologist didn't call any pneumonia, but the AI showed some color, and because of that, we ordered a test. I said, well, what did the test show? And the answer was, well, it takes 24 hours to come back. It turns out that test was positive. That patient was diagnosed with COVID early, before symptoms. Patient was proactively hospitalized, did not need critical care, went home safely. And to me, that was a really great example of the AI finding a signal that we would not have found otherwise as a human. And that's the kind of promise I think the technology holds when deployed appropriately.
Thank you, Dr. Longhorst. Thank you, Mr. Chairman, for your